Welcome to this new webinar and welcome to all and thanks to be there. And I'm very proud to have with us today again Professor Raymond Stein, that is the Director of Pediatric Urology and Reconstructive Division Urology in Mannheim, and that you know very well because he's supporting us very well, participating to very many webinars. And today we have a new entry with us that is Dottoressa Claudia Gatti. And Claudia Gatti, actually, she's working in pediatric surgery division in Parma, in north of Italy. I would like to introduce to you her. And she worked before with me in Rome in Bambino Gesù Hospital, and now from 20 years she's working in Parma. In Parma there is the oldest and the main spinal bifida center in Italy, where is also the venue of the Italian Society of Spinal Bifida. And today we will go to present a missing topic, because we know, and it is our fault of physician, that many times we miss this topic about fertility and sexuality. And I'm going to present the greetings and from Dr. Zimak, that is involved in an emergency and can be present with us. And I hope that we will enjoy this meeting. And I would like to start with a short introduction before to lead the podium to the two colleagues. And please, Darren, will you start with my introduction? Thank you very much.
Dear all, welcome to the webinar of today that will be focused on fertility and sexuality in people with spinal bifida. The sexual right of all persons must be respected, protected and fulfilled, according to World Health Organization, including people with spinal bifida. People with disabilities are not asexual. All people are sexual beings, including children, adolescents with spinal bifida or other dystrophies. People have the right to sexual expression, and individuals with spinal dystrophies need to receive our support. People with disabilities are not forever children. There is a common lack of sexual education for children, adolescents with disabilities and their relatives, including people with spinal dystrophies, because there is the fact that they don't need it. They need an age-appropriate sexual education because it's very important to provide some key topics to discuss, as sexuality and feelings, anatomy, puberty, menstruation, change in the body, erection. To educate people to different kind of relationship. Acquaintances is different from family, friendship, dating, marriage. It's very important the consent, because people with disabilities are more susceptible to be abused. They need to be educated to have care of themselves, self-care, hygiene, independence, self-esteem, protection, unwanted pregnancy prevention, to prevention of sexual transmitted infection, how to express emotion properly, and concern with these people are related how to find a partner, lack of confidence, concern about physical pain during sex, concern if they are able to have children, fear of what other people may think, and continence management. And here is our role. Sexuality in people with spinal bifida exists, as reported by different authors. As you can see, they report masturbation, sexual intercourse, partnership, satisfaction in man, in woman, with a different percentage in presence or not of hydrocephalus. The same for pregnancy that is reported in women with spina bifida. And as you can see, there is a different percentage of cesarean section, but there is a rate of pregnancy, and we have to think about that. We have also to consider, regarding their sexuality and relationship, about the gender dysphoria that is described in this people. And we have to educate also from practical point of view for the sexual life. And this paper is very interesting to read with a very useful practical suggestion. Sexuality in people with spina bifida. We know that we have a precocious puberty, that the liver lesion is strictly related to their sexual activity, that the erectile function can be improved, that the pregnancy is observed, as you have seen, that the fertility preservation must be considered. But we know that there is a big concern that there is the lack of information. In the recent guidelines that we have published, the sexuality and fertility topics is still reported with a weak level of evidence. For this reason, I believe that the presentation of today by Raymond Stein and Claudia Gatti will be very useful. Thank you very much, and see you later for the discussion.
Well, thank you very much for Darren for your support. I would like to leave the practical point of this webinar. So please, Professor Stein, the podium is yours.
Good evening. I think Giovanni already did a lot of introduction, and I will talk mainly about the sexuality and andrological aspects in the spina bifida populations concerning the males. And we know that due to we have a much better interdisciplinary care for patients with spina bifida, and this in the end decrease the morbidity and increase very much the life expectancy with all the guidelines we have. And therefore, sexuality and fertility have an increasing import for these people, and it's significant for their quality of life. Also together with continence and all the other things. But this is especially puberty and later on really a theme where we should have take care of it. And a couple of years ago, we did together with Conrad from Indianapolis and these groups a survey about the sexual activity and function in males with spina bifida, not only males, also in females. But we did this online, and in the end, we had the response and questionnaires from 162 male patients coming from 24 countries, and 11% are from Germany, and about half of them from the US. And when you see the age range, it represents those who are sexually active, 19 to 73 years old. So 19 was the lowest age. And quite a lot have a shunt, as usually, and almost 40% are walkers, so they are wheelchair bound or they are partially wheelchair bound. And what I think is interesting to see is that only half of them using CIC and catheterization. And this, I think, maybe also, so there is still, besides sexuality, a lot of things to do with the continence states in these patients. And you see that 71% had at least urinary incontinence in the last 4 weeks, and fecal incontinence, half of them. So there's a lot for us to do, but today I will focus on the sexuality. And when you look at the outcomes, sexual desire is almost similar to the whatever called normal population, so what is within the questionnaires. But more than half of them are really dissatisfied with their sexuality. So there's a lot of things to do. And coming to this study, there are more than half of them has at least some relationship or sexual activity within the last 3 months, which is quite a lot. And almost all 50%, they have some sort of sexual intercourse. So they are active. And also the first sexual contact is not so big different from the normal adult group, whatever normal is. And when you look on the other hand in the other studies which have been done and shown there, and also Giovanni showed the one from Verhoeven from Utrecht, many studies reported that only up to 40% are sexual active. When we did this questionnaire, which was completely anonymous, we saw that almost more than 50% are active. So I think it's a representative collection we had. And when you see there, 1/3 is living with a partner, and a few have a living, the partners living apart. And on the other hand, for almost 50%, mostly wheelchair-bound patients don't have any relationship. So there's a lot to do with this too. Gatti showed longer time ago that the general sensitization, relationship, and contact, it depends on the level where you have your spina or your lesion. And when you see group 2, when you have a lumbar or a sacral spina, then definitely what is normal, you have better sensation, and also this feeds on the end of sexual contact and these things. So the lesion plays a role where it is. And on the other hand, yeah, but more than 3/3 of the patients who has no relationship, they want to have one. So we can help them to, I think, them or to motivate them there. This, I think, is one of the things. And how is about erections? So when you see about 120 patients reported about this, almost 20% do not have any resections, and 20%, 1/5, have which is not sufficient for sexual intercourse, and only 40% have it. So this was a study of Rose et al. And there's also a good correlation with the mobility of these patients. Fortunately, not with a shunt, and fortunately not with a bladder neck surgery where we can injure the nerves. So this is nothing. On the other hand, not many patients in this group do have bladder neck surgery. So to keep in mind too. How about ejaculation? In our study, 80% had ejaculations. Almost all of them were walker. That's not, and 2/3 or 3/3 of those who were wheelchair bound. 15% no reported almost normal ejaculation. Most of them reported dribbling, and in 25% it was not unknown. And this is the same with other studies where usually they reported a dribbling or a retrograde ejaculation, which is logically due to the lack of sympathetic stimulation and innervation. So this is, I think, related to the lesion. And also in our study, 70% had orgasm. So it's quite a lot. And also most of them are walker, which is also shown by the study of Gatti that it really depends on the lesion. And when you have a low lesion, then you usually have a walker. And also this is seen in other studies where all the people who had air orgasm, usually they are walkers. And it's rather independent from the shunt status of they have a shunt or not. So that's good to know. And also, what is about sexual dysfunction? We use the EAF, which is, and 27% filled it out. So It's quite a low number. And we know all, I think, that the International Erection Index of erectile function is not really sufficient to pick up the sexual or the um, this erectile dysfunction in this group of patients. So I think in the future we need some more modification of it. But in those who responded, a lot of them had a erectile dysfunction. And on the other hand, when you use a erectile hardness score, which I think is much more reliable in the spina bifida group, only 11% had a good erection and 7% a moderate. So there is something to do. And you see, we're not the only one. Raghu, and 1 year ago, we published all these, and there is a lack of control of sex, reduced sensitivity, and urine incontinence. All this plays a role if they have a poor EAF and sexual erection dysfunction. But CEF, I think, is a very good tool to start a discussion with a patient about sex. And I think always when you talk to the patient, it's good to have something, an entrance. And I think there is this questionnaire quite easy to use to start and tell them that it's not expected to be have very good scores, but we can talk about what is related to the sex. And also we know, and you see here, 1/3 of the patients we ask say use PDE5 inhibitors. And with these, when they use it, 80% do have better erections, and some have a better, or most of them have a better sexual intercourse. And interestingly, there is no correlation with the lesion. So that's good to know. But when it comes to sensibility, only 23% do have full sensitivity. And even this, I think, is a little bit overestimated because I think they want to have it, but I think it's a little bit too high. And I think this is more realistic that most of them have a decreased sensitivity, and especially wheelchair-bound people who have a high lesion, they don't have any sensitivity in the genital area. What I found also a little bit found interesting is that sex is erogenous zones. It's not only related to the penis, it's also related to other organs. So this is something which you should also keep in mind, and especially in wheelchair-bounded patients. An option, but I never used it, is a Tomax procedure to get a little bit more sensitivity in the area where you anastomose the ilioinguinalis nerve to the nervus totalis penis. And then at least you see some have a groin sensation, some have a clamp sensation. So this may be an option, but to be honest, I never recommended or used it. Fertility, I think, is a problem in spina bifida patients. We know that a lot of them have undescended testes. Some of them have a very small testes. Some of them have a lot of epididymitis. And when you look at some of them had a good sperm investigation, there are very few patients who really have a normal spermiogram. And when you look at biopsies, it's also not very good. But these are biopsies in those who already seek for infertility treatment. And when you see there are very, very few studies about how fathering children, and when you see there are only a few who were succeeded. So fertility, I think, is affected by spina bifida. So in conclusion, men with a spina bifida, they do have a desire for sexuality, and we should respect this, and they have the right to do this. And also patients without relationships, they want one. Maybe we can talk to them, peers can talk to them how to get in touch with peer groups. And as more mobile the patients are, as better the sexual function is, as lower the lesion is. So I think this is good. And a fulfilled, this is something we have to tell the patient. Fulfilled partnership is not only synonymous with penetrative sexual intercourse. So we have to keep this in mind. And also there are non-genital erogenous zones. And this we have to tell them too. Treatment with PDF inhibitors, it is successful. We know this. On the other hand, we know that fertility is significantly limited. And I think also those who have the wish for fertility, they should go also for consultation with the genetic people, if it makes sense, and what to do and how high is the risk and so on. But on the other hand, if you want to have children, artificial insemination using ICSI, I think, is a good option, especially if you have retrograde ejaculation. And what we learned in all this study, we do need sex therapy and psychotherapy in these patients. And it's really necessary and it's useful for them. And we should offer this, which may be difficult in circumstances, but at least we should be aware of this. And also what we don't know exactly is about the endocrinology. How good is the sexual, is the endogenous function, endocrine function of the testicle and all these things. There are studies going on to investigate this, and it looks like that it's a little bit impaired. And I think studies as this are urgently needed. Thanks, and happy to answer any questions.
Thank you very much, Raymond. Very, very clear presentation with many topics for discussion. And if you agree, I can suggest to leave the discussion at the end of the presentation. So also I believe that could be useful for all to receive different point of view, because we have a different culture, different experience, and it could be useful to share. And Darren, please, will you be so kind to start with the presentation? Yeah, thank you.
Okay. Good morning, everyone. I'm honored by this opportunity. I will talk to you about education to sexuality in spina bifida patients and healthcare providers. My name is Claudia Gatti. I am a pediatric urology, and I work in University Hospital Parma. In 2009, we published this work on the Journal of Urology. Regarding sex education, these are the results. Most of spina bifida patients receive an adequate sex education. 78 males and 71 female patients have a good knowledge of sexual function. 20% men and 27% women have an adequate knowledge of sexual function. Only 1% have not received any sex education. In male patients, the most important sources of information on sex were friends and newspaper and television. Only 5% of patients have been informed by a physician. In female patients, the most important sources of information on sex were parents and school. Also in this case, only 5% of patients have been informed by a physician. Social media were not widespread at that time in Italy. A Boston group in 2015 reported that young people with spina bifida had difficulties in finding answers to questions regarding sexuality. Moreover, a need for help from medical community is necessary to empower patients in the area of sexual health. Roland in 2020 underlined the need for education about sexual health in spina bifida patients and discussed the spina bifida sexual health and educational healthcare guidelines. Tong and Tanaka in 2020 summarized current literature on sexual function, knowledge gaps, and the importance of tailored sexual education from providers in women with spina bifida. A 2018 manuscript evidenced how pediatric urologists are not trained and do not feel prepared to provide sexual and reproductive health education for young spina bifida women. Last year, the Italian Society of Pediatric Urology decided to investigate how pediatric urologists deal with sexuality and fertility in complex urogenital malformation. And 26 items multiple choice questionnaire was sent to all members. 60 centers were involved, and as we noticed, 45% of centers follow 20-50 patients, 18% of centers more than 50 patients. Most of the centers have a multidisciplinary team, but a dedicated sexologist is present only in 25% of the center. All sexual issues are investigated, like masturbation, sexual intercourse, erectile dysfunction, ejaculation problems, vaginal lubrication or discomfort, and dyspareunia, but only few centers use validated questionnaire. Sexual preference and gender dysphoria were investigated. All the interviewed pediatric urologists stated that they would be more trained regarding their gender identity. We can notice that only 30% of the center are confident with GIDYQIA questionnaire. In conclusion, what is necessary? Point 1, a more structured transitional pathways for managing sexual issues in spina bifida patients. And point 2, pediatric urologists must be improved counseling in sex education in spina bifida patients. Thank you for your attention.
Thank you very much for the presentation, and I would like to invite both to be present for the discussion, and I will start with a question for Raymond Stein that I received from the audience, is regarding the supplementation with the vitamin D for increasing fertility and sexuality. Do you have any experience for this? Do you have any to recommend?
To be honest, no. I don't think that it makes a lot of sense, because the problem that you have there is mostly due to retrograde ejaculation. That's one thing. This will not be affected by vitamin D. And the other thing is that usually you have a smaller testicle and very few sperm. So I think this will not really help in the end.
Mm-hmm.
And I think also in the infertility treatment, it's maybe it's a little bit more than a placebo effect, but I don't think so.
Yeah.
I don't know what your experience, Claudia, about this.
We have noticed that there is a recent publication in a gynecologist paper that reported that low dosage of vitamin D are present in overweight patients. And we have not a direct experience, but I think that when we have a lot of patients, especially women in wheelchairs, that are a bit overweight, and maybe this is can explain the low level of vitamin D in these patients. Mm-hmm. That influence fertility, because I remember that the ovum is the level of vitamin D is linked with the possibility that the implantation of the embryo in the uterus, maybe. I remember something like that.
Yeah.
That is from the female side, yes. But from the male side, I think
no.
It's good for the pharmacy to use vitamin D, but I think, and it may be good for the health too, but I think for fertility in male, it doesn't fit.
Yeah, and there is another question always regarding supplementation. What about folic acid? Do you believe that could be useful for improving?
For pregnancy in females, yes, definitely.
Yeah.
But it doesn't it brings it down to 0, but it reduces it around 50 to 80%, but it don't bring it down to 0. So still, I think there are other factors which influence the risk for getting another child with spina bifida, but you reduce it with folic acid, and you really need to take it quite early. Means
okay,
before you plan to go to pregnancy, then you should already start it.
And this opens another point to discussion that is not only related to the scant knowledge of pediatric urologists, but also regarding to the other specialists. Because in my experience, we have only one center for delivery that is able to focus our patient for the. And as your experience, do you believe that there is a knowledge that is so common between gynecologists regarding fertility and sexuality and pregnancy for women or not? What do you think?
Ladies first.
No, because my impression that we have to work as pediatric urologists, but also the other colleagues also to increase.
I think there's a big discussion also how to deliver these kids.
Yes.
And we have in our series also quite a couple where the urine diversion, even we looked for them where the urine diversion and get pregnant, who didn't use did a normal delivery and without any effect on the child and only with no effect on the continence and stool management, which is also, so I think it's gynecological reasons should lead the kind of delivery. If it's from the anatomical point, okay, that you can have a normal delivery. Otherwise, you can do a C-section, but I think it's not recommended to do in every female with a spina bifida to do a C-section. It's I think it depends on gynecological factors. So.
Yeah. Also related to the experience, what do you think, Claudia? Because in Italy, for example, we have a very high rate of cesarean section, and
yes,
not in all women. And
I have read a recent publication about this problem, especially in females that have a prior urinary tract reconstruction surgery. And so I think they say that vaginal delivery is not contraindicated, and they point out that the cesarean section is necessary only when a bladder reconstruction was performed. But I think in Italy, it's when I asked to a gynecologist, okay, this is spina bifida with reconstructive surgery, they said, okay, cesarean section, 100%.
Yeah, but there is but there's no real evidence that it's absolutely necessary. So
yes, true.
From the feeling here, you may feel that it's more appropriate to do it, but there is no good evidence that you have to do it, because the incontinence and these things, even after reconstruction, even if you have the augmentation and these things,
okay,
most of them have a stoma.
And Raimund, on the basis of your experience, because you have been involved in our recent activities for guidelines, urological guidelines for spina bifida, but you have been involved also in the past with the neuro-urology guidelines for pediatric patients. And what do you think could be useful to develop some specific recommendation for fertility and sexuality issues? Because in all guidelines, urological guidelines, but I haven't seen also that is missed in other guidelines, we have a very few statements. Of course, we have very few evidence, but also not as guidelines, but as a recommendation and position paper, maybe could be useful to have some common point to recommend. Because, for example, you introduce the role of sex therapists that in some countries, as in Germany, I suppose, is more frequently present in the center, and in the North Europe maybe more, but in some countries as Europe, as a Southern Europe, as in Italy, we have a different concern. I would like to report my experience with the Tomax procedure. I visited the center in Zwolle. I work with Max Overgur in order to transfer this procedure in my center. But when I come back and I focus on the physical to the sexual rehabilitation protocol, I understand that it was very difficult, if not impossible, to transfer this procedure to my country, because of course we haven't in our team a sexual therapist, and we need someone to educate people, that because they gain sensitivity, but they are not able at the beginning to discriminate between the different stimuli. And so what do you think? Do you believe that we are ready for starting a common position paper or recommendation for that?
That's a difficult thing, because recommendation you can make, but also I said the wishful thinking is with sexual therapists and all these things, but we have very few in Germany, and even I tried to establish it in our center, but just now I failed with a grant, so it's difficult to get these. On the other hand, when you come for recommendation and guidelines or whatever, you should include andrologists and gynecologists. And what I think, as you said, with the C-section and all these things, I think it would be even much more important to have a common recommendation or guidelines together with gynecologists about how to deliver a child for example, in spina bifida patients with or without reconstruction. And also what I think is very important is how to deal with the medical treatment in pregnant females, because anticholinergics are usually contraindicated when you are pregnant, at least in the first couple of months. So what to do with these patients and so on. I think this would be quite important to have there some recommendation, which I think is even more important than about sexuality and therapy for sexuality. I think this is also important. But if you think about something like this, then I think you have to include the themes too, and also respect what is available in different countries too.
Yeah. Claudia, what do you think about that? You agree? Yeah.
Yes, I agree completely. I think that there is a great gap between the north part of Europe and the southern part. In Italy, it's very, very difficult to strictly follow guidelines and also to create a unique protocol between the various centers.
Okay. And we have a question regarding education, and I represent to you. And can you please elaborate how and when you start discussing sexuality and fertility topics, young adult and adolescents with a spinal bifida, in relation to transitioning them to adult care? I love to hear about that, about the different experience in Germany and Italy. So please, what is your thought?
I think that sexual health should be viewed as a continued discussion, and the best will be to start in childhood and gradually building through adolescence. In Italy, I think that we start too late because parents consider the adolescent like a child, and they continue to consider like a child even if the patients became adults sometimes. But I think that it's important to start very, very early with the sex education, also to improve the self-esteem of these patients that sometimes they lack.
Yeah, but you don't answer to my question, and I would like to be more precise. Do you start to introduce the topic with your families or patients, or you wait that they ask to you?
No, so we start in the last 8 years, we start to introduce sexual aspect during the adolescence.
Okay, so at the age of 10, 12?
12, 13.
Okay.
Yes.
And
sometimes they ask in women patients before that time.
Okay,
Raymond, what is your experience?
We are later. I usually start during puberty or a little bit later with them about sexuality. So to be honest, it's maybe a little bit late. That's true, but then we have, I think, sometimes a better and a good, more reliable conversation with a patient or with the adolescent. It's not only a patient; it's an adolescent. It's something you have to speak to. So we do it a little bit later, maybe a little bit too late. I don't know, but then we also we talk about hormones and we talk about how to get better erections and all these things.
Okay, and do you believe that could be useful and to share, to discuss about this topic also with the families, with the from the beginning? Because for me, it's quite surprising that in the few newborn that we have, for example, with myelomeningocele, but in other cases, the diagnosis is more common as for spinal dysrhythm associated to anorectal malformation. And so we have a diagnosis normally about 1-2 years old, no more. And they ask about the ambulatory status, the continence, the fecal continence, but very few ask about fertility and sexuality. And it could be useful to prepare something to have a common approach, because I think that receiving patients from different areas of Italy as a third level center, I see that there is a very large difference between the north of Italy and south of Italy as a different approach. I don't know if it's the same in Germany or Claudia, if you agree, and with the mostly is related to the culture of the sensibility of the families, of also of the doctor.
I think that I agree completely with you. I think that when we treat patients with anorectal malformation, for spina bifida is a bit different because the parents start very early to ask about sex and yes, and fertility. But in my experience with anorectal malformation, the last problem for parents is sexuality and fertility. They are only focused, especially with fecal continence after urinary continence, but sex is not a problem for them.
Raymond?
Yeah, I agree, but we don't see huge difference from the regions, I think.
Okay.
This is maybe also due to the spina bifida organization where they just, most of them are like, they're definitely, yeah, even to be honest, cultural things are maybe even also not the same. There are no big differences, even if you have Muslims or Catholics and all these things. In the end, it's a little bit more free but as I said, it's they are older. We don't start with 12, 13, we start a little bit later, yeah.
And Raymond, one question by me, and because we don't have, and I would like to know if you have something about that in Germany. Do you have some pamphlet, some practical not guidelines, but publication for families, maybe done from the Spina Bifida Association regarding some practical point that could be lubrification for sexual intercourse, protection for by sexual transmitted disease, or also how to manage, how to have sexual intercourse, because of course these people maybe would like to receive also practical suggestion how to do, because I remember a very interesting presentation during a meeting of East Coast Society that is for the spinal cord injury. If I remember, was a presentation by a Swedish group that was presenting the different practical suggestions how to have sexual intercourse between a woman with paraplegic and man no, or the opposite, and so on, in order to give to people, to families, and to, of course, to patients, because they are mainly focused on adult patients, how to have a normal sexual intercourse or sexual life. And do you believe that it could be useful to prepare something, maybe involving someone of adult center?
Useful, definitely. We don't have it, yes.
Okay. Claudia, what do you think about that?
I think that will be a great idea to prepare a pamphlet with some suggestion for the family. Will be great. Maybe not only in Italy, but also in all Europe, so to have a unique paper.
Okay. And one question that sometimes I would like to, I know the answer, but I would like to discuss for the audience. Sometimes we have the question about the relationship between fertility and clean intermittent catheterization. If there is some risk about to start with a clean intermittent catheterization because of the fear about infection and so Raymond, could you be so kind to represent to all the risk or no risk of a clean intermittent catheterization and fertility in men, especially?
I think when you do, I think it doesn't have any influence except when you produce a lot of epididymitis, but you get this epididymitis usually only when you have bad bladder and UTIs and all these things. And this
Yeah.
may, so the CIC, I think it may even improve the fertility because you get a bladder cleaner, you get a better bladder function and all these things. So it's good.
Yeah.
On the second hand, it's not, it has no impact on the fertility directly, but indirectly because you have a better bladder and all these things. So this, I think, helps. But it's, yeah.
No, thanks, because it's a common question when I propose clean intended catheterization, and I would like to share. And also because, of course, with a better bladder control, we can avoid orchiepididimitis, but also we can improve continence. That could be something very useful for people in order to start relationship, because increase the self-esteem, and also if they have a partner, of course, could be improve the sexual life, and in order to facilitate. And regarding the what is most overlooked in the regarding the sexuality fertility, more the male aspect or the female aspect? Raymond.
I think the male aspect is for fertility, I think is more important. For the females, they are usually more or less fertile, but pregnancy and all these things is complicated. So I think for fertility to introduce pregnancy or get pregnant, I think females has a little bit more advantage than males.
Mm-hmm. Claudia?
Yes, I think that also for female it's easier.
Mm-hmm.
It's yes, it's a bit because I think that when in my experience when I treat these patients, I've noticed that the more complicated cases, the fear to be not very performance
Mm-hmm.
is linked with men, not with the women.
Okay, and I've seen that for many cases the fertility and sexuality is overlooked also generally as attention, because maybe as I introduced the topic is related to disability. For me, it's surprising how we have many papers about fertility in the oncological patients, for example, or in the SD, and maybe because are more not popular, but it's easy to discuss about that instead to discuss about fertility and sexuality issues in disabilities. We have received a question from all the audience regarding again the supplementation of vitamin D or acid folic in spinal muscular atrophy. I believe that in all patients with disabilities, there are some points that are in common that are overlooked because it's difficult for people to consider this aspect, and maybe we have to work in the future to improve. And regarding the multidisciplinary team, who is dedicated to discuss about that in your team, Raymond? Do you have psychologists to treat, or you as urologist, or the same for female or male, or you try to share, to discuss you as male with a male patient and your colleagues, female colleagues with a woman? Or
we have the advantage more or less as we are at least 50% in our centers are urologists. So we have this transition, and we talk to them personally, if the females, if it comes to pregnancy and or if it's expected and or it's discussed, we have a good relationship with our gynecologist, but we don't have it almost together. And psychologists, it's a disaster.
Okay. And your team, Claudia?
So we are 2 pediatric urologists, women, not men.
Okay.
Okay. And we have not sexologists, but we have 2 dedicated psychology. One is a man and the other is a female. And we ask all the patients, do you prefer a man or a female or a woman to discuss your problem? And we want that the patient decides.
Yeah, I would like to report my experience, because you have the advantage to work in a general hospital with adult team too. I work in a pediatric hospital, and for me it's surprising sometimes that patients, of course, and adolescents or young adults ask directly. So please, you're giving me good suggestions, but I would like to move to another center. And maybe because it's easy for them moving to adult center to leave the parents outside the room and from discussion, and are free to discuss directly with the specialist. Okay, now at 7:30, yeah, we have finished our time. I don't see any other question. And thank you very much for your participation, Raymond and Claudia.
Thank you.
I hope that the meeting was interesting. We will come back in May with another webinar. And thanks again to Darren and Parmida for the fantastic support for the organization. And thanks to Omninet, International Federation of Spina Bifida, and also to the EARN that support these activities. And if you have any question, please, you are able to send us later, and you can see again the webinar if you like on the YouTube. And for the certificate, you have seen the suggestion by Darren Sheenan. We will come back the 15th of May with a webinar on the living with spina bifida, face-to-face meeting. And we will be proud to have with us Dr. Silvia Rusen, that is the General Secretary of International Federation of Spina Bifida. And then we will come back in 19th of June for discussing the topic about bowel dysfunction. Thank you very much to be there.
Thank you. Thank you, everybody.
Thank you very much again.
Thank you.
Have a good night. Bye-bye.